Hi all, welcome to the start of the semester. Hope you guys are enjoying the nice weather so far. And here's the Women's Health Topics series. This is just a couple of lectures kind of combined into one, focusing mostly on hormone replacement therapy and some of the uses for hormonal therapy. So we'll start out with contraceptives. So contraceptives, along with some of the other medications we've talked about throughout the years for blood pressure, or throughout the year for blood pressure and diabetes, and probably fall into some of the most commonly used medications on the planet. You have probably a number of women at any given point in time that are using oral contraceptives. So they estimate there's probably about 80 million women using oral contraceptives at any given time, although it's difficult to actually predict that. It's a highly reliable form of contraception, so the big caveat being taken correctly. And it's got about a 0.1% chance of pregnancy with perfect use. So again, very reliable method. And you have to remember that people aren't perfect, of course. So generally, studies have shown with what we call typical use, which would just be people taking it without, if you pool everybody, not everyone's going to take it as directed correctly every time. There's going to be people who take miss pills or take doses at different times, and so you get about an 8% chance of pregnancy overall. So it actually doesn't sound that great, right? So when you hear about people who, they got pregnant on the pill, well, it is possible, and especially with a 8% chance with typical use. And so failure to resume therapy post, placebo period, those types of things are really common too. So anyway, when you take it absolutely correctly, it should be a pretty fail-safe method of birth control. However, there's of course that human error factor that you have to take into consideration as well. If we want to talk about depot injections and IUDs, they're much more reliable. Compliance isn't really a problem when you think about it with those. So IUDs specifically, basically you get the same percentage, so it's like 0.1% or whatever. Geez, my computer likes to update things all the time. So anyway, you have a product that is essentially doing the same thing. So they're hormonal, but they are going to provide the medication in a bit of a different mechanism and delivery, but you're getting a fairly similar rate of the perfect use, if not a little bit better. And then you take away all the compliance issues. They do have some issues with them, and as far as like placement of the IUD and those types of things, but a trained physician or practitioner should be able to figure that out with enough experience with the product. As far as the ring and patch, which we'll talk about all these separately, by the way, so I just want to go through some of the rates here. But the ring and the patch have pretty similar failure rates to oral alternatives. They both have their compliance and adherence issues. You'd think they might be a little bit better with adherence, but statistically they're shown to be about the same. Most products contain both progestin, a progestin derivative, and estrogen compounds. So usually we're talking about combined oral contraceptives, if you've heard that term before. And the hormonal amount has decreased significantly. So when these products were originally developed, relatively speaking, compared to today's products, the hormone content was actually quite high. The dose was high. And then over time, we've pushed that dose lower and lower because if we can get the same contraceptive effect with it without the same side effects, that's ideal, right? Just like with any drug, we want to use the minimum dose effective to treat the patient's symptoms. In this case, not really treating a symptom, but preventing pregnancy. So how can we do that without causing as many side effects? We'll talk about some strategies here and some of the different doses out there without further ado. So this next slide shows you, just to talk about pregnancy rate, if you want to compare things to like condoms versus withdrawal method to, I think, do they have natural family planning on here somewhere? Well, there's no method. So I think what they're looking at here is typical, or what does this say? Data refers to number of pregnancies per 100 women during first year of use. So if 100 women are having sex for a year, they have an 85% chance of getting pregnant, basically, if there's no method whatsoever. And then you have different factors here. So you can see that IUD, whether it's Mirena, and I don't think they have the Skylar here, which is the newer one, but you have the copper, or it doesn't really matter what it is, but it's got a less than 1% chance, and correct use and typical use is the same. That's really the only thing that's like that. Even the Depo-Provera injection, for whatever reason, the correct use is good, but the typical use is 6. So I think there's a problem with that, with overlapping the injection and how long it takes the injection, because depots take some time to get from the deposited drug in the muscle to actually absorb systemically. And so it does take some time for that to ramp up, where IUDs are much faster. So it's just a matter of understanding when you need your next injection, getting it on time, and making sure you are waiting the appropriate period of time before having unprotected sex. And then you can see there's a bunch of other ones. Oh, here are the fertility awareness-based methods. Yeah, like the natural family planning type things. Typically use about 25% chance of pregnancy there. So again, nothing's really that great with the exception of the IUD. So that's really the only sure bet if you want to look at it that way. But you're looking at 10% chance of pregnancy with some of these other products. So it's pretty consistent across the board. And of course, you could look at things like vasectomy or female sterilization, of course, should have very low rates as well. All right, so 2 components generally. We'll talk about some progestin-only products, but let's talk about the estrogen first. So estrogen is kind of easy to remember as far as the compound, because it's only one thing. So all oral contraceptives are going to have the same type of estrogen. It's called ethinyl estradiol. It was originally discovered in 1938, so it's been around for a really long time, and it's orally available estrogen product. It's the only one on the market, I think, that I know of. There might be some other derivatives, but it is the one that's used in birth control. And again, virtually all oral contraceptives, unless they're a progestin-only pill, are going to have ethinyl estradiol in them. Standard dosing is around 30 to 35 micrograms, which I'm not going to test you on. However, it's important to know that when you see products labeled as low, like for example, some brand names market themselves this way. So orthotricycline low, low estrin, a low estrin FE has 10 micrograms in it. So there's some products that just push this quite a bit lower, and that's actually getting more and more common for lower dose estrogens. So there's a couple things that the estrogen is going to do. Prevents the pituitary gland from releasing luteinizing hormone, and with no luteinizing hormone present, the egg doesn't mature and ovulation does not occur that way. So that's really the primary mechanism. We're going to loop back to mechanisms here a little bit and talk about them, but that's really the major thing estrogen does. So moving on, talking about the progestin component. So there's a ton of different progestin components. That's really going to be the biggest difference between product to product. Now, the ethinyl estradiol strength can vary, so that's going to be one difference. But when it comes to different progestins, they do a lot of different things, and they might act differently. And I'll show you some comparisons here in a little bit. So you might see things like norethindrone, norethindrone acetate, levonorgestrel, norgestimate, drospirenone. There's a ton of different ones. They all do basically the same thing from a contraceptive point of view. There's not a whole lot of difference there from efficacy, but they're going to cause different side effects in the patient taking them, and some people may tolerate certain ones much better than others, or they might like some of the effects of one versus not like the effects of the others. And basically, if you're looking at a pack of birth control and you're like, what progestin component is this? Well, it's the one that's not ethinyl estradiol, right? So remember, ethinyl estradiol is kind of like the constant. The dose can change, but that drug should always be in a combined oral contraceptive. It's the other drug that is the progestin component. What else? Oh, all progestin components have some residual androgen activity because they're derived from testosterone. So that's really a big difference between some of them, and we'll talk about specifically why this matters. But some have much more androgen activity than others, and that can create a different set of side effects, sometimes beneficial, sometimes detrimental. All right, so when we're talking about these progestin products, you have a couple different things. So you have first generation, second generation, and third generation, and then kind of what we call unclassified. And generally speaking, the more you get with different generations, you're going to get some varying androgenic activity. But other than that, there's not a whole lot of difference, and it's not even all that predictable to say that a third generation is going to be less, although generally speaking, the further the generation, the less androgenic activity they have. Here's a chart that shows this a little bit better. So high levels versus middle versus low. This is probably a decent thing to remember because if birth control is oral contraceptives are challenging because they have so many different brand names and there's so many different generic equivalents, and all the generics go by their own weird brand names too. So when you're trying to decide, like let's say you have a patient who is on a levonorgestrel product and they're having a lot of acne. Well, maybe you want to go with a low androgenic activity one. So you're like, let's try a drospirenone product. Okay, so you can use this type of a chart, or there's other ones that exist out there that are probably more user-friendly than what I have here. But basically, you get the point, right? You can try and figure out how to tailor your progestin component to the patient and what type of side effects they're experiencing, so they get a drug that works a little better for them. All right, so let's talk about mechanisms. We've talked about the concept of combined oral contraceptives and the different products, and let's loop back a little bit here and talk a little bit about mechanism of action. So stepping back to estrogen, we talked a little bit about how it suppresses gonadotropin releasing hormone and pituitary gonadotropin secretion. So what that does is it inhibits mid-cycle luteinizing hormone surge. This basically prevents ovulation from happening. So this is a really powerful mechanism of contraception that the ethinyl estradiol component of the drug is providing. So when you sub out just for a progestin only product, you're losing this mechanism essentially. So not quite as effective. Now there's a lot of other mechanisms that progestin provides that ethinyl estradiol doesn't. So you get a mixed bag. Now birth control, the important thing to remember is that there's not just one simple mechanism to it. So there's multiple, and it's like, I think when you count them all, there's 7 or 8 different mechanisms that it actually prevents pregnancy with. So there's quite a few fail-safes involved here, which is why they're so effective. Suppression of ovarian folliculogenesis. So the pituitary follicle stimulating hormone is suppressed. This process might not actually occur with some of these really low doses, so it's something to think about, that you might not get quite as efficacious oral contraceptive. However, again, these are all FDA approved, they're all studied, and they all basically proven to be non-inferior to each other. So it's really probably not a big deal in the long run. Suppression of ovarian steroid production via suppression of gonadotropin releasing hormones. So there's a number of different, again, ways this works. So progestin has a couple different mechanisms too. So it has effects in the endometrium, so it renders it less suitable for implantation, which might cause eventual atrophy. This can be problematic, especially if you have a progestin-only pill. You might get a lot more breakthrough bleeding. Alterations in the cervical mucus can help decrease permeability to sperm, and impairment of normal tubal motility, and peristalsis. So again, several other mechanisms here that complement the estrogen very nicely. So when you combine them all, you get a very synergistic approach to contraception. And just for the record, this diagram is kind of funny, but you do not put a birth control pill inside the vagina, just for the record. You'd be surprised at, I know that sounds ridiculous to even say, but some patients, and I've heard stories of this, that they were using pills in this way. And we actually had a patient in one of the pharmacies I worked at when as a student who was actually doing this, believe it or not. So it's one important thing to remember to educate patients. These are oral contraceptives, meaning you take them by mouth, right? Very important. So don't show them that diagram. All right. This is something that you've probably reviewed in a lot of different physiology classes you've taken, and maybe in high school biology too. It's probably something everyone's somewhat familiar with anyway. And this just shows you the different hormones that are going on. So when we're talking about luteinizing hormone suppression and the spikes of estrogen and progesterone, by manipulating those, we can basically prevent this natural process from occurring. That's really all I want to talk about with that. All right, so how do you start a contraceptive in somebody? This is a great question. There's a number of different ways to do this. Well, actually, there's like 2, so I guess 2 is a number, right? But then there aren't a lot of choices. But you can see this flow chart, which looks kind of confusing. It's really not. So you're looking at the first day of the last menstrual period. If it was more than 5 days ago, you start the method today, but you want to still use a backup for another week. That's a pretty common way to do it. And that's, again, basically your last menstrual period was quite recent. If it's been more than 5 days, take a urine pregnancy test if it's negative, and you've had unprotected sex since the last menstrual period, which would make it impossible to test on a pregnancy test in case you did have a very early pregnancy. You have a number of different options here. So if the last unprotected sex was less than 5 days ago, or less than or equal to 5 days ago, excuse me, you offer hormonal uh, contraception today. Advise that negative pregnancy test is not conclusive, but hormones. So again, you want to make sure you're giving that caveat. Same thing with the 5 day, and same thing with the both less than or greater than 5 days ago. So if it's greater than 5 days ago, advise negative. And you want to start a new method now. Yes, the patient does. That's why she's in the office, right? She wants some contraception. So start the pill, patch, ring, ingestion, use backup method for the first week. Or start the new method today, even if taking the contraceptive today. So there's, again, a number of different options you can do. I put some other things here, which are some more common ways that, again, this flowchart can be a little bit confusing. It's sort of bogged down with all these questions and things. But some other options. So Sunday, oops, what's going on here? Thank you for choosing Norton. Yes, great. All right. Anyway, so other options. Sunday start. You have a start pill on the first Sunday after the person's period begins. Use backup contraception for 7 days. It's an easy way to explain it to somebody. There's also the first day start, which is begin the pill on the first day of menses, which means that the backup contraception is not needed. This is a nice way to do it. So basically, you prescribe the product to the person. You say, all right, next time you have your period, the first day you get it, start taking your oral contraceptive. And then you don't need any backup contraception because it's during your menstrual cycle. And then by the time you're done with your menstrual cycle, you're basically covered at that point. So really, there's a number of ways to do it, but basically, if you're going to start somebody at any point, backup contraception for 7 days is like kind of the rule of thumb here when we're looking at different options for starting people on oral contraceptives. All right, so again, it's not all that complicated. I think there's, this flow chart makes things a little convoluted, but if you kind of focus on these ones, either the patient wants to start it today, and you're basically going to use backup method for a week. If not, you're going to have them probably started on the first day of their next menstrual cycle, and then you don't need to use backup contraception at all. So how to start. So you have a couple different options here, and again, we sort of talked about this already, but this just lays it out there for you in case, and it also puts things on there with the other methods of delivery, like the implant, injectable, which would be like your Depo-Provera, and then you have the IUDs. So IUDs can be started, any of these can be started anytime, so there you go. That's easy to remember. Additional contraception, so if you don't need backup, and if you do at all, copper-containing IUD, you don't need any backup at all. They work very quickly, and actually you can use a copper IUD as a emergency contraceptive in some cases. It works very quickly. The Mirena, or the levonorgestrel releasing IUD, if more than 7 days after menses started, use backup method or abstain from sexual intercourse for 7 days. And then the other ones have some varies. Usually it's 5 to 7 days for whatever reason. Who knows what they studied it in, or some of these, I think maybe like the Mirena takes a little bit longer because it's a very low dose. Systemic wise, your progestin exposure with Mirena is really, really low versus like an oral contraceptive where it's going to be quite a bit higher, your plasma serum concentration, because it's working locally and it's providing those effects locally. There is some systemic effects as well, but it's very minimal compared to like a combined oral contraceptive pill. All right, so tablets come in these colorful, nifty packs that have all sorts of different looks to them and all kinds of different interesting names, like Porsche and Nordet, and all the generics tend to brand them like this is I don't know, this is kind of an old company. I don't think Bar still exists, but they look like this. So the funny thing is that the products have come out with a variety of brand names. So, for example, orthotricycline or orthotricycline low is probably one of the most common ones. Now, the Yasmin products are very popular. So, as far as brand names go, once these products go generic, these companies, for whatever reason, I don't know who started this trend, but instead of calling them, drospirenone and ethinyl estradiol, which is a lot to talk about or write on a prescription label, right? You can just say it's Portia or Nordet, and it sounds very exotic maybe and fun. I don't know. I think it's kind of silly, but you'll notice that all these generic products have this name, which makes it really confusing for pharmacists and providers to keep them all straight, because like one company's Portia might be equivalent to another company's I don't know. I can't think of another good example off the top of my head, but you get the point, right? They all have different weird brand. They're kind of considered branded generics, like the generic companies making their own brand of the product, which is sort of an interesting sub niche. But very few instances of this actually occur, with the exception of your oral contraceptives. And really, I think it's like, yeah, I take Nordet. Well, there's some value to that, I think, because as a pharmacist, I can type in Nordet to a computer system and figure out what exactly it is and find some equivalents of it and figure out what specifically the drug is. However, it does make things confusing because it's a lot of double checking. So the point I'm trying to make with talking about weird names of birth control, and you're like, why are you rambling about this, is that it's really important not to mess it up, because there's subtle differences here and there. You always want to make sure you're prescribing the same product or an equivalent. So let's say a patient is in your office and they're on something. Maybe they say, well, I was taking this Porsche product, but they said the manufacturer discontinued it, but I was getting some side effects. So again, you want to know exactly what that person was on. You want to know how much progestin, what type of progestin, and you want to know how much ethinyl estradiol was in there. So that being said, and just always make sure you're double checking these things. There's a lot of references out there. I don't think I attached any here, because I honestly don't care that you know about the different ones. I'm not going to test you specifically on some of these, with the exception of one, which I'll show you here in a second. But at the end of the day, it's just very convoluted. And anytime you're dealing with switching oral contraceptives, changing doses, substituting products, you always want to make sure that you are double checking what exactly you're dealing with first. So with that being said, let's talk about some instructions. So we talked about perfect adherence and compliance. These are very effective medications. What does that mean for the normal person? How do you get to that 0.1%? Normal use. Take at the same time every day. Don't miss doses. This is a really key concept that I think a lot of people might miss. The hormones, when taken orally, don't last all that long in the body. It's not like you have a few days buffer in between if you miss a dose. The levels will drop fairly quickly. So if you take one in the morning one day, and the next day you don't take it until bedtime, that's a potentially long enough period in between doses that you're going to end up with a drop in blood concentration. With missed pills, so single missed pill isn't usually a big deal. You just want to take it as soon as you notice. Even that means taking 2 pills together. So let's say you miss a dose one day, you wake up the next day, you normally take it in the morning, and you're like, oh shoot, my Monday dose is there. If we look back at the packs here, you can see that they usually have days on them, which helps people with compliance here. And there's little notes like start week 2, week 3, week 4. Placebo pills, oftentimes colored differently. You'll see like this is an orthotricycline, so there's different strengths here, so they're all different colors. So anyway, you miss a dose, you get your next pill, you say, oh my gosh, it was Monday yesterday, and I took my dose, or I forgot to take my dose, so now what do? Well, you take 2 doses now. No additional contraception is needed. That's probably enough. If you get 2 or more missed pills, you want to take one of the missed pills as soon as you notice it, and then continue your regular schedule. Now, this is where it gets a little tricky. So if the pills are missed during days 15 to 21 of a 28-day pack, you finish the hormone pills, start the new pack, skipping the placebo pills, and then you use backup contraception for the next 7 days. If it was before 15 days, you just want to continue, and you still want to use backup contraception for 7 consecutive days. It's a smart thing to do. I think a lot of people, this is maybe one of those where you get that high percentage increase as people miss a day or two, and because maybe they went out of town and forgot the medication, when they come back, they retake it, and then they don't use backup contraception. So there you go. Extra pills. Resume normal schedule. Don't skip days. If you end up early, you can, it's usually not a problem to refill your medication like a week or so early, so you can just, resume when you normally would. No big deal there. Return of menses. Usually patients will get return of normal menstrual cycle within 30 days after stopping the pill. If not by 90 days, they might need to be followed up on, basically. So everything should go back to normal within about a month after stopping oral contraceptives. All right, so types. We've talked about the different drugs in them, but there's lots of different types of them within these. So to make things even more confusing, so there's 21 and 28-day cycles. The basic difference here is that 21-day packs just don't have placebo pills. Some of them might be a 21-day pack with like a 4-day placebo period. So basically you're doing like a 25-day cycle. It doesn't matter really. You can certainly do things one of two ways. The patient can get their period, start a new pack, or they can just skip the placebo pills altogether and continue. So there's some that are designed to be continuously used, where they'll come in like 84-day packs or whatever, and you basically just take it continuously, and you only do a placebo period every 3 months. So this might be more convenient for people who don't want a menstrual cycle, or maybe they have strong symptoms associated with their menstrual cycle. However, breakthrough bleeding is much more common the longer you stress this out. So the endometrium will eventually atrophy enough with a progestin component, even if there's estrogen on board too, you'll end up with the issue of just breakthrough bleeding and atrophy. So it's recommended to let the placebo kick in every so often, and not just go like years and years taking continuous oral contraceptives. Mono versus multiphasic. So this is another newer, well, it's not even that new. It's been around for a while, but it's one of the newer ones if you want to look at the entire history of oral contraceptives. So monophasic is just the same dose of hormones throughout the entire pack. Pretty straightforward. And that's pretty common still. Even with a lot of the newer products, a lot of them are still monophasic. Multiphasic, basically the concept is that you give a lower total amount of steroid, but you're getting the same efficacy rates of contraception. So for example, orthotricycline's a product like this. Now, the fixed dose estrogen is always key. So you aren't varying the estrogen dose at all. What we're varying with the multiphasic is the progestin component. There's no proven clinical benefit with this. However, some patients may tolerate a cyclic better. That's really all there is to it. So if you want to try orthotricycline low versus cyclin low, or whatever the non one is, there's tons of them that aren't cyclical like that, or multiphasic, I should say. And really, again, no clinical benefit. However, patients may tolerate certain ones better. Okay, side effects and risks. So these vary widely based on the type, dose, and the route. The most common side effects are related to the estrogen component, and usually patients will experience bloating, nausea, and breast tenderness. This is usually what happens when you start taking an oral contraceptives, and likely resolves over a few months. Now, the big side effect of venous thromboembolism is probably the most highly touted issue when it comes to oral contraceptives, and there's lots of lawsuits and things like that go on about this, and people say, well, one company is worse, or blah, blah, blah. We'll get to that here in a second. So basically, higher estrogen doses are associated with increased risk of venous thromboembolism. However, risk is prevalent in both low and high doses. So when you're looking at total amount of risk, we can skip down to this bullet point for a second. The risk is extremely low. You're looking at about 3 to 13 cases per 10,000, which is much lower than pregnancy postpartum, which is about, I think, like 70 to 100 cases or like 1 in 1,000 cases, maybe, if you want to look at it that way. Not quite there, but similar. So in a healthy woman, it's very rare to see this. Now, maybe with a low dose one, you get closer to the 3 to 5 range, and a high dose one, you get maybe closer to the 10 to 13 range, something like that. But the bottom line is the risk is very low no matter what. However, there hasn't been a good study that shows that taking a low dose estrogen component actually reduces your risk all that much. So it's kind of interesting. Older and heavier women are at higher risk, and thrombophilia disorders are at much higher risk. So people with factor V Leiden, which is a genetic clotting disorder, makes your blood more likely to clot, and specifically puts you at risk for venous side clots like DVT and PEs. It puts you, so taking that disorder, which is more common in men, so it's unusual to see it in women, but do, and they also have an oral contraceptive. I actually think if they're homozygous factor V Leiden, it's a contraindication, but I could be wrong. I think I have something on that later, so I shouldn't speak out of turn here. But anyway, it is an issue to consider. The problem is most people have no idea they're factor V Leiden until they have a VTE, and a lot of people will go through their whole life never having it, so it's difficult to know if they are actually at risk or not. What about cancer? You actually have an increased risk of cervical cancer. Mixed data on breast and liver, likely no issues there. Other side effects, weight gain, pretty inconsistent data. The strongest data for weight gain that I've heard of is with the Depo-Provera shot. The progesterone-only shot could cause more weight gain than the other ones. Most of the other ones don't necessarily have a lot of weight gain data associated with them. It's kind of inconsistent reports. Breakthrough bleeding, most common side effect of oral contraceptives. So again, your breakdown of the endometrium. The lower the estrogen dose, the higher the risk of bleeding. So here's where you can do some tailoring of your dose of ethinyl estradiol to help your patient out. So if your patient's having breakthrough bleeding, you want to increase the dose of estrogen. What if they're already at the max dose of estrogen, or they're already in a high estrogen product? Well, at that point, you might look at see how they're taking it. Are they skipping their placebo period? It's difficult to say at that point. You might just have to, you could try maybe an alternative option, maybe like a IUD or something like that would be better for a patient like that if they're getting a lot of breakthrough bleeding. Stroke risk. So stroke risk kind of goes hand in hand with the VTE risk. However, it's not on the venous side necessarily. Very, very low risk in women under age 35. In fact, we don't really care about it. Slightly higher in women over 35. Much higher if you're over 35 and smoke. Kind of compounds it. So that's a contraindication. People who are over 35 and smoke should not be on oral contraceptives. And this is a good bargaining chip, if you want to look at it that way, as a practitioner. If you have patients who are getting to that point, maybe they're in their low 30s and they're getting, they smoke, and you're trying to get them off smoking, you're trying to get them off forever. You can say, well, once you get to 35, I'm not going to be comfortable prescribing your birth control anymore, and no one else is either, because we don't want you to have a stroke. So anyway, use it to your leverage if you can. Higher risk with migraine headaches. So if somebody already has migraine headaches with aura at any age, I actually think that's can be a contraindication totally as well, which is sort of interesting. Myocardial infarction. Mixed studies, likely extremely low rates, not a high risk thing that we're too concerned about here. And I've got a list of contraindications here in a second that I'm going to show you while we're on that same train, but let's just talk about anti-androgens and some of the controversy associated with VTE. So while we're on the same line of side effects, so this product came out, drospirenone, a little while ago, and the products that use drospirenone are all the Yaz products. So they're Yaz, Yasmin, Bayaz. Basically, the difference is Yasmin and Yaz are the same. Yaz has a slightly lower amount of estradiol, and Bayaz is the same thing as Yaz. It just has some folic acid supplement in it. So the reason why that could be, why the drug company thinks that is important is because they say, well, if you decide you want to stop your Bayaz and you want to get pregnant, your folic acid levels are already good to go. You don't risk any chance of spina bifida. You don't have to supplement at all with folic acid because you're already fully good. You just have to go into your natural prenatal vitamins and then you're fine. It's kind of a scam in my opinion. I don't really understand the benefit of it. And if you just if you really were thinking about that, maybe just take generic Yaz, because Yaz comes generic, Bayaz isn't. Take your generic Yaz and take a prenatal vitamin with it. That's pretty easy to do. So again, it's kind of a silly thing, but that's in case you're wondering what Bayaz is and if it's any better. It's not. It's kind of a scam. Associated with greater VTE risk when compared with levonorgestrel. So here's the big thing. with these products, and what you might have heard, or maybe you haven't, I don't know. I think it was in the news a bit ago. Got some bad press on this product, and that people were getting more VTE with these products than they were with, standard levonorgestrel product. So risk is still quite small. It's still lower than during pregnancy, and it still falls within that 3 to 13 per 10,000 person. So it still falls within what we'd expect. It's just on the higher end of the spectrum, and that's really all there is to it. It's not necessarily all that more dangerous, but if you want to look at it where maybe on a product like levonorgestrel, it's more like 5 people out of 10,000, and maybe on your YAS you get 10 out of 10,000. Again, very low relative to each other. There's not a huge change there. Or sort of like absolute percentages, very tiny amounts. Relative, it's a double. So you have that to consider. Marketing has caused less bloating, acne, weight gain, helps with PMS. So it's marketed with all this stuff. And the FDA got kind of mad at them because they're like, well, you're saying that it cures all these things. And so that's where the concept of premenstrual dysphoric disorder came from. And so it actually does have an FDA approved indication for this premenstrual dysphoric disorder. It's just supposed to be kind of like the technical term for really bad PMS symptoms, is from what I understand it to be. And because it's an anti-androgen product, so meaning not only is it very low androgen activity, it's actually anti-androgenic. You shouldn't get the weight gain, the acne, the bloating as much. So anyway, a lot of people like Yaz because of this series of side effects that it theoretically doesn't have, whereas most other birth control would cause some degree of that. These are really popular for this reason. Okay, so we talked about some of that stuff. Let's talk about some specific contraindications. Over 35, smoking more than 15 cigarettes a day, contraindicated. Cardiovascular disease, contraindicated. People with uncontrolled hypertension, contraindicated. History of VTE or active VTE, contraindicated. I don't know about history, actually. I think that means active VTE. History, I think you'd want to figure out what the issue was specifically. If they had a VTE on an oral contraceptive in the past, I would definitely probably not prescribe it again. Thrombogenic mutations. History of ischemic heart disease, history of stroke, compilated valvular history, lupus, migraine with aura at any age. This is an interesting one because migraines are, of course, more common in women than they are in men. So you could get, and in young women too, so you could get an interesting dilemma with this. Breast cancer, cirrhosis, hepatocellular adenoma, or malignant hepatoma, which could mess with the metabolism of the hormones. So there you are. Most of these are related to clotting, right? So that's the biggest thing. Migraine with aura is a very interesting one, though. So why, that's related to the increase in stroke risk, but it's sort of an anomaly as far as something to remember, I think. Drug interactions, these are CYP metabolized, so they're metabolized through the cytochrome P450 system. Enzyme inhibition, we generally aren't too concerned about this. Azole antifungals in grapefruit juice may cause higher serum estradiol concentrations, so that might actually increase some side effects, potentially, specifically VTE. Enzyme induction may decrease efficacy, so phenytoin, carbamazepine, phenobarbital, rifampin. Antibiotics is probably the one that maybe is the biggest urban legend about oral contraceptives. So can you use antibiotics and take oral contraceptives? Well, yes, for the most part, yes, there's not a big deal, but it's kind of controversial. So here's the reason why. All sex hormones undergo enterohepatic recycling, meaning you excrete them via the bile, they get reabsorbed and recycled through the body. Great. It's a nice way that the body reuses stuff that it can do without resynthesizing the hormone. And the problem is that your GI flora is critical in this recycling process. So anything that disrupts the flora will diminish the efficacy of the hormonal contraception. So that means that if you're taking an antibiotic and it's wiping out part of your GI flora, you could potentially be risking the enterohepatic circulation of this of the sex hormones, specifically these oral contraceptive hormones that you're taking, decreasing the contraception's efficacy. Overall, this has not been proven. So most studies have shown that this is not a risk and that this actually doesn't have any clinical effect. However, it is a theoretical concern. So You can always tell your patient, I'm going to prescribe you 7 days of Cipro for your UTI. You might want to use backup contraception. If your patient's extremely paranoid about getting pregnant, maybe it's not a bad idea. But again, there's not a lot of evidence to actually support that is necessary. So again, controversial and question marks there. Other St. John's wort may induce the SIP system, so if they take that can increase or decrease efficacy by increasing metabolism. HIV drugs can have a whole slew of effects, so take that on a case-by-case basis. Non-hormonal oral contraception is the product, the NuvaRing, or non-oral hormonal contraception. I'm not sure if I said that wrong, but anyway. So you've got two products here, the NuvaRing, which is used intravaginally. It's a once weekly for 3 times a week, and then 1 week without. When you can remove this product and rinse it with warm water and then reinsert it, you get about a 3-hour window that it can be out without any complications. These are combined, but by the way, both of these products are combined contraceptives. They're just non-oral. So they both have an ethinyl estradiol plus a progestin component. NuvaRing had this big controversy recently, kind of like Yaz. Or the Yaz products did. And with the NuvaRing, basically they found that the VTE was on the high end of that risk. Again, that 3 to 13 per 10,000, they were maybe like 11 or 12 per 10,000. So again, higher risk, but still within what we'd expect and still lower than pregnancy. So Merck had a number of large settlements due to this. So they got some really bad publicity. And the NuvaRing took probably a big hit as far as its popularity. It's kind of an interesting product, I think, from a delivery standpoint. So it delivers the hormones locally, but it does absorb systemically, of course, because you have these side effect risks too. It's really a unique delivery mechanism that allows for a more convenient application of the product for most people. Some people might think it's a little bit weird, but you do get the ability to remove it and reinsert it if you need to. Ortho Evra. The patch, again, has a pretty low dose of estradiol, but the thing is that the estradiol exposure can be about 60% higher due to the transdermal absorption. So there's a thought that this has a much higher VTE risk. However, that hasn't really panned out, but it's possible. I think there's some company developing a lower ethinyl estradiol patch, but I haven't seen it yet. 1 patch for each week, 3 weeks. And then 1 week patch free. So it's similar to how the NuvaRing works. It's not recommended for use in patients over 198 pounds, not 197. Those patients are apparently still good, but 198 pounds is the cutoff for whatever reason. That's what they determined during their clinical studies due to poor absorption, decreased efficacy, and just with the transdermal going through more subcutaneous fat, just having issues that way. This is the NuvaRing, in case you're curious and have never seen one. They're about this big. They're kind of actually large and relatively thick from what I thought they would be. The interesting thing with this doesn't dissolve, so this is a polymer and it releases drug out of it, and the NuvaRing will stay fully intact during the time. The Ortho Evra can be applied in multiple discrete locations, which is helpful. So you can show it right on your arm if you want, or you can put it in a place that people can't see it as easily. Non-oral, some more non-oral options. So Depo-Provera is medroxyprogesterone. It's a progestin product. It's an IM shot every 3 months with no estrogen component, and again has the highest weight gain associated with it. IUDs are 2 of them I've listed here, but there is a third called Skyla. So again, you have interesting names for these products. Mirena and Skyla are both levonorgestrel. I think Skyla is technically supposed to be like a generic equivalent of Mirena, but Mirena doesn't really have a generic per se. They have a bit different of approvals. I think Skyla is only approved for up to 3 years of use, where Mirena can be approved up to 5. Very few contraindications to these products. Significant reduction in menstrual blood loss and dysmenorrhea, and about 75% of women will still ovulate while on a IUD. And I have another, I think, chart on IUDs here in a second on how they actually work, so we'll come back to this in a minute. Copper IUD is a little bit different, can be left in place for at least 10 years, maybe longer, but patients might get heavier menstrual cycles. So how do IUDs work? They prevent changes in cervical mucus and inhibit sperm transportation. So that's one of the biggest things. So copper IUDs might increase the copper concentration, which thickens the mucosa and helps to prevent motility that way. The hormone releasing ones might just do that effect locally. Remember we talked about progestin products and how that was one of their mechanisms. Well, it's just happening locally there. Chronic inflammatory changes in the endometrium and fallopian tubes. Spermicidal effects inhibit fertilization and implantation by kind of causing this mild inflammatory process. Thinning of and atrophy of the endometrium, which inhibits implantation. Again, you're using very small amounts of drug very locally with when we're talking about like Mirena and Skyla compared to an oral contraceptive. So the effects are not substantial. Now, that's one of the biggest side effects with an IUD, and usually it goes away for most people, but a lot of people can get breakthrough bleeding for like 1 to 3 months when they first get their IUD. That's probably one of the, I think from what I've read, one of the biggest issues with adherence is that some people will just get so much breakthrough bleeding that they don't want it anymore. It just never goes away. It's always inconvenient. But eventually, for most people, the body will get used to it, and then your breakthrough bleeding will diminish over time. So if it's really inconvenient for your patient, you can take it out and try something else. But that's one of the probably the biggest adherence issues with it. Yeah, this picture is kind of funny. I was trying to find one that showed about how big the product was, and so this person's tongue works as a good size comparator, I guess. So you have these products, and they're about the same size, so that's about how big they are, in case you were wondering. Hormonal contraception uses and benefits outside of contraception. So other things you can use these medications for are hyperandrogenism or androgenism. Is that the right word? Androgenism, yeah. Usually due to polycystic ovarian syndrome or ovary syndrome, dysmenorrhea, menorrhagia, hypothalamic amenorrhea, and then there's a number of other ones. Acne, or other types of things too. Anti-androgens might be helpful for that. Decreased cancer risk, potentially. So there's a number of reasons why these drugs might be used. I don't think anyone's necessarily going to take oral contraceptives to decrease their endometrial, ovarian, or colon cancer risk, but it's possible. But some people might take them, if they have acne and they also have a desire to have contraception. It might be something that is worth trying. So there's that to consider. Lactation. So hormones are excreted in breast milk and may pose a risk to the infant. Estrogen also, probably more detrimentally, can decrease overall milk production. So usually during lactation, while it's difficult generally to get pregnant while breastfeeding because that has a natural contraceptive effect on the body, it's certainly possible. Even if the patient hasn't necessarily had a period yet, it's still possible. Actually, my sister-in-law got pregnant while breastfeeding because she thought she couldn't. You definitely can. It is unusual. I think it's like a 90 to 95% contraceptive rate just from breastfeeding alone. However, again, that still leaves a window of opportunity there. So barrier methods are preferred generally for breastfeeding. However, you can use progestin-only products. So there's a pill called the mini pill, which is the brand name of it, which is kind of dumb, but it doesn't appear to affect breast production at all. You do get breakthrough bleeding on it because it doesn't have estrogen component. However, it is effective contraceptive. And then the Depo-Provera and IUDs are going to be good options, especially if the patient isn't. Depo-Provera is fine at any time. IUDs are good for somebody who's maybe not going to have another kid for a while. So postpartum, you want to wait about 4 to 6 weeks to put it in because you can risk uterine perforation. And then after that, it does need to be confirmed placement with the physician or whoever's putting it in. So those are just some things to keep in mind as far as using the IUD postpartum. But it's a really good option for somebody who is is going to not be having children for a couple of years and wants a birth control that they can not have to worry about. It seems like a pretty good bet. I think IUDs have a lot of advantages, and I don't know if I'd say they're underutilized because I think plenty of people are utilizing them. But when you compare a lot of their advantages, if somebody is looking for a long-term birth control option, you get a very good, very low failure rate with them. So there's just something to keep in the back of your head as an option for patients. Emergency contraception. So this is the last slide in this set, and then we'll do the second set of slides here later. But emergency contraception. So candidates for these would be people who had recent unprotected intercourse or recent contraceptive failure. So maybe they forgot to take a bunch of pills in a row and had sex, or they had a condom break or whatever, and no other contraceptive plan on board. So that might be something to consider. There's really three options here. So there's high dose progestin, which is levonorgestrel, Plan B, and basically it's just a single dose of high progesterone. It delays ovulation. It's about 50% effective after 72 hours, and it diminishes in return after that. It's the most effective as soon as you can take it. So it goes up substantially after, within 24 hours, and then it diminishes substantially after that. After 72 hours, it's not really all that effective. And it's much less effective in obese women. Women who are heavier, I think over 80 kilos is the cutoff usually when we say we should definitely use Ella, which is the next drug. It also has behind the counter status though. So, however, if you have to be over 17 to actually buy this without a prescription. Okay, sorry, I just paused this so that I could check this out. Actually, this has been lifted. It's no longer behind the counter. I actually don't know if I've seen it. Maybe some places choose to keep it behind the counter. Good old auto formatting here. Let's see. So basically just over the counter. And I don't think there's an age restriction on it either. So that was something that I think what I read was a couple years ago they passed in the Minnesota legislature. That could be different state to state. So that's just a Minnesota thing that I was able to find. But anyway, Plan B is probably going to be the most common one. Unfortunately, it's not the best. Ella is the best. Ella was lovingly referred to as Plan C. However, it's really more like Plan A now. So why is Ella better? Well, it's got a different mechanism. So it prevents progestin from binding to the progesterone receptor, which delays ovulation. So it's got a different mechanism. It's not a hormonal product. It's sort of like it's a targeted receptor binding thing. Data shows efficacy for up to 5 days, and that doesn't diminish. So it's not like you're 4 days out and you have worse effects than if you're 1 day out. It actually is about the same. And data shows better efficacy in patients over 80 kilos. So for those reasons, Ella is almost always preferred. For example, like in our emergency urgent care, when we have people who come in with either unprotected sex or sexual assault victims, they always get Ella. That's the primary drug we give. The problem with Ella is that it's not over the counter. I think it probably will be at some point, but it's not right now. So Plan B is going to be one that people can get easier. So one thing I will say about Plan B, in case you're curious, is you might see Plan B one step or like the old Plan B. When Plan B first came out, you're supposed to take one tablet immediately and then another one 12 hours later, which people may or may not forget. It's just as effective to take both tablets at the same time. So never tell somebody to split it up. Just have them take it all at once. Easy that way. Copper IUDs is another thing that you could try. It's 95% effective within 72 hours, and you just put the IUD in, and it works quite well that way. NSAIDs as emergency contraception, not an ideal thing, but do have an abortive effect potentially in some cases. So, all right. With that being said, I'll post this lecture, and then we'll come back and we'll talk about a hormone replacement therapy in another series here in later in the week here. I think I'll get that up. So anyway, enjoy this one and enjoy the nice weather. Thanks.